So this is a pretty rapid whip through of some of what I thought were the major trials done over the last 10 years, so over the last decade. If you are after the slides, very happy to provide them. I think Michelle may have provided them to you, but if not, very happy to try and get them to you. So you can just try and sit back and I'll rapidly go through everything. Disclosures are mainly related to academic bias rather than anything in particular. In terms of what I'm going to cover, there'll be 4 studies related to energy delivery. Well, actually 3 trials, and there's got to be a bit of self-promotion there at some point, so that I'll be the 4th one. Indirect calorimetry, look at 2 very important trials that have been discussed in a little bit of detail. PN, haven't included EPINIC because that was more than 10 years ago, but the calories trial and Nutria trial. Then we'll look at protein, a systematic review, very important study by Leanne Chappell, and post-caloric feeding, Andrew Davies' trial from Enteric from 2012. So in terms of this study's been initially presented, so it's Todd Rice and the Eden trial, initial trophic versus full enteral feeding in patients with acute lung injury. So the background is that many of the putative benefits of enteral nutrition may come from trophic feeding, and full feeding may actually cause harm. And so the ARDSNet group wanted to evaluate whether trophic versus full feeding for 6 days increased the number of ventilator-free days in patients with acute lung injury. It was a multi-centre study, open label, parallel group, randomised clinical trial. There were 1,000 patients enrolled. The intervention was 10 kilocalories per hour, and that was for the first 272 patients, and then it moved to 20 kilocalories thereafter. The control group was standard intervention, and the outcome of interest was ventilator-free days. So that's if you die before day 28, you get 0 ventilator-free days, and if you are extubated on day 4, you get 24 ventilator-free days. So this is the nutritional data, which showed that the trophic fed patients, actually there was a large treatment separation, that those patients who were receiving trophic feeds did receive less calories, a fairly low calorie, very trophic feeding for 5 days. And this was the primary outcome data, ventilator-free days. There was no difference in the primary outcome, and you can see on the bottom part of that slide there is survival in the top curve, so that the number of, that's the time to survival curve. So there was no difference in ventilator-free days or in the time to survival at day 90. As part of this study, they also did sophisticated follow-up work looking at health-related quality of life, as well as a fairly sophisticated battery of tests in those patients that they could get back to the clinic, and they managed to do that in about 500 patients, so that was a very impressive effort. That didn't show any difference in that subgroup, the nested cohort, with the longer term follow-up. So the summary was that in patients with acute lung injury, a strategy of trophic feeding for up to 6 days did not increase ventilator-free days or reduce mortality. And I guess, how has this manuscript influenced my practice? Well, I haven't adopted a trophic feeding approach for this group of patients because it didn't show superiority, and prior to this, I didn't have a trophic feeding approach. So the next study was the PERMIT study, which was published in the New England Journal in 2015. And this looked at the thought that calorie restriction while maintaining protein might improve outcomes, with the thought that there wasn't enough protein given in the Eden study. And they wanted to evaluate whether permissive underfeeding, so a slight difference that you're not providing as many calories, somewhere between 40 to 60% of estimated calorie requirements, which is different from trophic feeding, while conserving protein delivery for a maximum of 14 days. Does that reduce 90-day mortality? It was a multi-centre trial, although there were only 7 sites. It was open label, parallel group, randomised clinical trial. There were 894 patients enrolled. The intervention was 40 to 60% of calorie requirements versus 70 to 100% in the control group, and the primary outcome was death at 90 days. This is the calorie intake. You can see that there was a marked treatment separation, but there was no difference in the protein delivery, which was a very reasonable amount, particularly for that time, protein that was delivered to patients. The primary outcome, so permissive underfeeding and standard feeding, there was no difference in the primary outcome. So permissive underfeeding did not reduce mortality. And so a feeding strategy of permissive underfeeding while maintaining protein for up to 14 days did not reduce mortality. And again, I guess prior to this, I wasn't a believer in the permissive underfeeding approach, so I didn't adopt it, but it did provide some very important data. The next trial is the target study, so led by Marianne and Sandy Peake, which Marianne's presented already in a little bit of detail today. And the background to that was that achieving 100% of estimated energy requirements may improve outcomes. And the objective was to conduct a multi-centre blinded randomised clinical trial to compare an energy dense formula, so 1.5 kilocalories per mil versus 1.0 kilocalories per mil at a dose of 1 milli per kilo per hour of ideal body weight to determine whether 100% of energy delivery when compared to 70% influenced mortality. So this is the nutritional data. We can see that there was treatment separation in terms of the calories delivered, and that was maintained whether you looked at calories just from trial nutrition or you considered the calories from all sources, and patients received about 25 kilocalories per kilo per day. This is the primary outcome of the target trial. So this was day 90 mortality. So about a quarter of the patients died before day 90. And the energy dense, so receiving 100 kilocalories per mil, that increased the point estimate to increased mortality of 5%, but it could have actually, the 95% confidence intervals included that we could have shown a 6% reduction in mortality or a 16% increase with achieving 100% with some sort of certainty. So we weren't able to show any difference at all with the primary outcome. And then we had a look at data at 180 days, so at 6 months. And I guess my thought was that before the study, before we undertook target, that we wanted to have a look at functional outcomes, because even if trying to optimize calorie delivery or energy delivery didn't reduce mortality, the thought was that it may improve functional outcomes, and particularly potentially in subgroups of patients. So if you're a young person, maybe it helped you get back to work earlier, or if you're an elderly patient, prevented you going into a rehab and then a nursing home, maybe put you on a different trajectory and improved things throughout your whole hospitalisation and got you back to your baseline function more rapidly. So the background to this one was that we really didn't know what the long-term effects were on things other than mortality, and we wanted to undertake a detailed analysis at day 180 to determine effect on quality of life, functional outcome and survivors. The EQ5D5L is a health-related quality of life. You're able to get a number, a numerical number between 0, as is in no quality of life or dead, to 100, which is perfect quality of life. And there was no difference in the primary outcome. So the group difference of 0 with a 95% confidence of 0 to 0. So we're very certain in this result. And on the on your right-hand side of your monitor, you'll be able to see that when we broke it into the individual components of the quality of life score, looking at mobility, self-care, usual activity, pain, discomfort, and anxiety and depression, there was no sort of clear signal there for any of these sort of variables that trying to deliver 100% of calories early on affected these outcomes 180 days later. And again, this was sort of some subgroup data, but we're interested. I thought this was probably one of the things where I thought beforehand that this may have an effect. So we wanted to look at all patients who were in a paid employment or in the labour force before they came into ICU. So we had 818 patients. And then we looked at those at day 180, and we found that while only about half of patients returned to work, and they took about 81 days from randomisation to get back to work, there was no difference in the amount of work that they were able to achieve, whether they received sort of the 100% calories while in ICU versus 70%. So in summary, a feeding strategy of energy-dense enteral nutrition formula when compared to standard enteral nutrition did increase energy delivery to approximately 100% of the guideline goal calories when we used a weight-based equation during the ICU admission. But the additional calories did not affect mortality, quality of life, or functional outcomes when quantified as a capacity to return to work, disability, or participation. And I guess, so in the absence of specific risk factors, these 3 trials done together, so, and when I say specific risk factors, sort of marked malnutrition or established chronic critical illness, I tolerate not getting to enteral targets for the first 7 to 10 days while I try to optimize enteral nutrition before considering other therapies. So I try, prokinetic therapy and postpyloric tubes before going for intravenous nutritional therapies. So the next section is on indirect calorimetry and parenteral nutrition. So in regards to indirect calorimetry, this is the first trial to discuss. It's by Matilda Allingstrom in Denmark, and it was the EAT ICU trial. This is an excellent methodology for a single-centre trial and really set a sort of new benchmark, I think, in nutritional trials for single centres. And the background to this was that individualised nutrition with indirect calorimetry and urea excretion may be able to improve physical quality of life at 6 months. It was a single-centred open-label parallel group RCT, 203 patients. The early goal-directed nutritional therapy was the intervention, and the physical outcome score of the SF36 was done at 6 months, was the outcome of primary outcome. It was a blinded assessment. There was a sophisticated statistical analysis plan that was really impressively done. There was a difference in the amount of protein delivered, so blue being the intervention early goal-directed therapy. So both protein and energy was delivered in greater amounts, but the primary outcome, which was the physical component score at 6 months, there was no difference in that primary outcome with the intervention. There was also no difference in the number of secondary outcomes. And so in this trial, individualising nutritional therapy resulted in more energy and protein delivery, but had no effect on the primary outcome or other patient-centred outcomes that they measured. And I really thought that how it influenced my practice, well, it did really influence my research practice because it did set a benchmark, I think, for trial methodology for conducting a single-centred trial, and the author should be congratulated. So the next study is the TICACOS international study, which has recently been published and been discussed a little bit at this meeting already. So the background to this: does the use of indirect calorimetry to measure resting energy expenditure to guide nutritional support improve outcomes? And sorry about the typo, but the objective was to test whether indirect calorimetry and aiming for 80 to 100% of energy requirements with or without supplemental PN when compared to control, just a calculated 20 to 25 kilocalories per kilo of ideal body weight using whatever protocol was done at that site. It's a multi-centred open label parallel group RCT. It was stopped after 6 years, as has been mentioned here. It was 417 patients enrolled of what they hoped to be 580. The intervention was indirect calorimetry with targeted energy delivery with high protein, plus or minus supplemental PN, compared to usual care at the sites. And the primary outcome was this interesting thing, which was called infectious complications. And they grouped all infections together. So they also included catheter-related urinary tract infections, and there was no adjudication panel. So I guess in regards to a research methodology, there is a little bit of concern about that as the primary outcome when you've got an open label trial and you're using outcomes, patients themselves probably aren't going to be that concerned about a catheter if they've got a catheter in and they develop an infection, as compared to more serious bloodstream infections and so forth. They presented data on the per protocol analysis, which was only 332 patients. And I should, given this setting, acknowledge that the trial was sponsored by a project grant from Baxter. So this is the primary outcome. And the secondary outcome data, you can see there's no difference whether we looked at the data related to a per patient or an intention to treat analysis. again, I'm a little bit uncertain with the mortality data, how that's actually presented. There seems to be less people passing away as time goes on, but there doesn't seem to be a reduction in the number underneath the curve. So I'm not sure exactly how those data get worked out, but there wasn't any huge difference benefit shown with indirect calorimetry. So I guess in summary, multi-centre RCTs evaluating indirect calorimetry are very difficult to conduct, but within the limitations of this study, indirect calorimetry did not affect outcomes that were measured. And so how has this manuscript influenced my practice? Well, unless there is a specific indication, and so a couple of those would be the extreme of weight, the patient that you're using high-dose propofol on, perhaps with traumatic brain injury or something, or you're getting into the more prolonged admission phase, so after day 5, day 7. I don't routinely measure energy and energy expenditure in that group of patients. So in regards to parenteral nutrition, so the calories trial was a trial of the route of early nutritional support in critically ill adults done in the UK. The background was the most effective route of nutrition was unknown, and they wanted to evaluate whether commencing parenteral nutrition is superior to enteral nutrition in patients with a functioning gastrointestinal tract, which I think is interesting to make people aware of. It's a multi-centre open label parallel group RCT. There were 2,388 patients enrolled. The intervention was parenteral nutrition for 5 days, comparator was enteral nutrition for 5 days, and the primary outcome was mortality at day 30. What I would say about this trial, it was not really an issue that I'd given much thought to previously. I didn't really think that a group of patients that I could enterally feed, I'd never sort of asked myself, should I be parenterally feeding that group of patients? And the other thing then is the sample size was worked out to detect an absolute risk reduction of 6.5%. So to give you an idea that parenteral nutrition or IV nutrition was meant to be saving one life every 15 or 16 patients that you were feeding enterally, did seem somewhat implausible and sort of lacked face validity. So this is the calories data, the nutrition data. As you can see, they gave about the same amount of calories, which was, again, a little bit unexpected. You did anticipate that those that were given intravenous or PN might have received more calories in the first period in particular. And there was no difference in the primary outcome of mortality or in any of the other secondary outcomes. The study, which perhaps looks at parenteral nutrition, which seem to reflect a little bit more of a clinical question that we often have, is the MANIC22 trial done by the French group. And really that wanted to look at, is enteral nutrition safe during periods of hemodynamic instability in critically ill patients? Because based on the guidelines at the time, it was felt that perhaps enteral nutrition should be withheld until patients were hemodynamically stable. And their objective was to determine whether it was so important that I actually spelled it twice, wrote it twice, whether early first-line enteral nutrition was superior to first-line PN in patients requiring invasive mechanical ventilation and vasosuppressive support for shock. It was 44 ICUs, open label, parallel group RCT, 1,410 patients were enrolled. It was early EN versus the comparator was early PN, was considered the control group. And it was primary outcome was 28-day mortality. And after the second interim analysis, the DSMB recommended, so the Data Safety Monitoring Committee recommended stopping the trial. However, this is a little bit unusual for investigator-initiated trials. Often with industry-sponsored trials, there is a futility analysis done, but often in investigator-initiated, you've received the grant already, and so you do try to see the trial through. And there was no specific futility analysis planned within the Data Safety Monitoring Board charter, which is done beforehand. However, the independent DSMB did decide to completing the trial wouldn't change the outcome at all. So this was the nutrition data, and as you can see, the enteral group did receive more enteral calories and hardly received any PN until the time that it was suggested. And there was no difference in the primary outcome, which was mortality at day 28, which we would expect with the futility. But I guess the interesting viewpoint or the interesting subgroup of this is that within this very large subset, they had bowel ischemia occurring in 19 patients, or 2% of the population that received enteral nutrition who were requiring high vasopressive supports. The things to note about this, though, is that only 10 patients within the enteral group actually received surgery. And I would suggest that if you had someone who you thought had bowel ischemia in any sort of clinical setting, that you would normally go on, they would have a laparotomy or some sort of surgical procedure to diagnose that, versus three patients in the parenteral group. But nonetheless, there is this signal there, although it's in a very small number, that perhaps it needs further consideration. So EN was not superior to PN for early nutritional support in patients treated with mechanical ventilation and vasopressors, but there was an increased number of GI complications with early EN. And so while it's not superior, it was not inferior to early PN, and my preference remains to use the cheaper therapy, although I think this goes into this growing body of evidence that, particularly in the ICU and within a randomised controlled trial at good centres, that PN is relatively safe, and we're a little bit uncertain what to make of the signal of EN and gut ischemia. In terms of protein, I'll just very quickly whip through the last three. So this is Kate Fetterplace's excellent systematic review and meta-analysis, looking at if you gave protein as compared to the ASPEN guidelines, compared to usual Australian practice, is there any difference? In this, at the bottom of the forest plot there, you can see that there was no statistical difference, but over about 413 patients, there was, the point estimate was an 8% reduction in mortality with more protein, but that could have, the 95% confidence intervals included anywhere up to a 37% reduction to a 35% increase. So we really have no idea of whether giving more protein actually does improve outcomes based on clinical trial data. Leanne Chappell did this excellent target protein study, which she's already presented earlier on today. So in summary, there is no robust data to support clinical practice guidelines, either AusPen or ESPEN, regarding protein delivery. And so we still need much more data in this space. Andrew Davies conducted this study with the ANZIC CTG, published in 2012. It looked at early post-pyloric feeding versus early intragastric feeding. It was multi-centred, open-label, parallel group, 181 patients with what at the time was thought to be a large gastric residual volume of more than 150 mils. And this was with what was at the time called a tiger tube, which was a spontaneous migrating nasojejunal feeding tube versus standard nasogastric feeding tube. And there was no difference in the amount of enteral nutrition that was delivered, which was probably due to the fact that you actually had to fast or not really augment enteral nutrition while this tiger tube was self-migrating, and it did not increase it. So the summary was it did not increase energy delivery when compared to protocolized intragastric feeding. And how that influenced my practice? Well, I think patients with large gastric residual volumes, I still administer prokinetic drugs and continue intragastric feeding, but I would still use the post-pyloric route in patients who continue to have large GRVs despite prokinetic drugs. So in the summary, sorry, it'll be a couple of minutes over time, but the practice based on the interpretation of evidence from these 10, sort of these important trials over the last 10 years, I don't get routinely underfeed or provide trophic only feeding, but I also don't get too fussed if I can't get to target rate with enteral nutrition in the first 7 to 10 days in the standard sort of ICU group. Indirect calorimetry is reserved for selected patients, and obviously this is not for the selected group. These guidelines, I guess, in ICU outcomes from EN and PN appear fairly similar. However, EN still remains cheaper. The optimal amount of protein is unknown, and for patients with large GRVs, I still use prokinetic drugs as first line, but I will use post-pyloric feeding for persistent cases. So sorry about the mad rush. Are there any questions on the...
We wanted to just dispute the 10-day mark.
Okay.
We think that probably 5 to 7 days, because a lot of the trials are, fairly short, that we would probably, be encouraging to try and escalate things earlier than 10 days.
No, that's fair enough.
And I guess the other problem is if I come to you at day 10, that really means day 12 before we actually start parenteral nutrition potentially. So, and maybe not for you particularly, but sometimes at some institutions it's delayed. So, you have to add on a couple of days earlier than what you want to start sometimes to have those conversations. The only other thing that's come up, and I did answer it, but you can add your thoughts, was is there any research around the need to fast patients prior to extubation, or can the NGT just be aspirated prior? And my comment was that some hospitals do not fast prior, and there haven't been any major issues with that, and that we need to do a trial in that space. But have you got any further comments about that?
So I guess most of the time I'm quite happy to feed up until extubation, and the thought being that it is quite rare that the patient immediately fails. So most of the time when you have a patient fail, they fail several hours down the track, so you've had several hours of fasting anyway. I think if what I would say though is there is the odd case where I would make that you would ask for the patient to be fasted, and the specific reason would be, look, this is a potentially difficult airway. I think the patient might fail straight away. I then want to go on and do a tracheostomy or something, but I need to show that they're going to fail. And in that setting, but it would be the odd one out rather than the default position.
And there's not any, do you know of any studies? I don't know of any studies that have been done, large studies.
No, I guess there would be difficulties though in creating equipoise, because there would be some people that would think that you would definitely have to feed until you stopped, until extubation, and there would be a group of people that would be absolutely adamant that they wouldn't pull the tube out.
And they know the answer already.
Yep.
Yep.